This lecture is over coagulation disorders. These information can be found in chapters 33 and 34 in your book. So what is happening in the body? First of all, coagulopathy is the term for any condition that affects an individual's ability to coagulate. Coagulation disorders occur secondary to an alteration in platelets, clotting factors, or both. Disorders are suspected when the usual measures used to stop bleeding fail. The liver produces prothrombin and other blood clotting factors. Refer to table 33.1 in your book. These clotting factors are activated in a sequence, leading to a clotting cascade. Final steps are activation of prothrombin and thrombin and fibrinogen to fibrin, leading to stable clot formation. Anti-clotting begins with a clotting cascade to prevent a disruption of perfusion and maintain a balance of opposing forces. Fibrinolysis starts with the activation of plasminogen to plasmin, with plasmin digesting fibrin, fibrinogen, and prothrombin. So coagulation or clotting is a critical, complex, multi-step process by which blood forms a protein-based structure or clot in an appropriate area of tissue injury to prevent excessive bleeding while maintaining whole body blood flow perfusion. It's the process by which blood changes from a liquid to a gel, forming a clot. It potentially results in hemostasis, the cessation of blood loss from a damaged vessel, followed by repair. The mechanism of coagulation involves activation, adhesion, and aggregation of platelets, along with deposition and maturation of fibrin. Disorders of coagulation are disease states which can result in bleeding, like hemorrhage or bruising, or obstructive clotting, like thrombosis. So 3 consecutive processes that cause blood clotting are platelet aggregation with platelet plug formation, the blood clotting cascade, and the formation of a complete fibrin clot. When platelets clump, they form large semi-solid plugs that disrupt blood flow to that area. These plugs aren't clots and they only last a few hours. They cannot provide hemostasis, but they can start the hemostatic process. Too few platelets present cause clotting impairment and increase excessive bleeding. Triggering the extrinsic pathway is usually a protective function that occurs when factors outside of the blood or that are abnormally present in the body activate platelets. Conditions or substances that activate the extrinsic pathway are inflammation, bacterial toxins, or the presence of foreign proteins. Triggering of the intrinsic pathway happens through internal conditions like impaired blood flow, such as venostasis, or excessive amounts of substances that promote blood clotting within the blood. These situations can activate platelets and trigger the blood clotting cascade. No matter which of the two is triggered, the end result of the cascade is the same: formation of a fibrin clot and local blood clotting or coagulation. So an injury occurs, spleen releases platelets if the current ones circulating aren't enough. The platelets head to the site to form a plug or platelet aggregation. They're not considered clots as they dissolve after a few hours, and they simply start the process. So remember that our body acts in a knee-jerk reaction, so at times it may try to do too much coagulating. However, when the original injury occurs and the whole cascade of clotting factors begin, the body also releases anti-clotting enzymes to help balance things out. So hence fibrinolysis, is released. So the injury occurs, the cascade of clotting factors start, but also the body releases anti-clotting factors like plasminogen that converts to plasmin. Plasmin helps control the size of the fibrin clot. You can refer to page 815, table 33.1, that lists the different clotting factors. So in the intrinsic pathway, these involves factors 12, 11, 9, 8, and then get to the common pathway factor 10. Extrinsic pathway involves factors 3 and 7. So think 3 plus 7 equals 10 for your common pathway. So clotting factors such as PTT or APTT, think play table tennis. And where do we play table tennis? Inside. So think intrinsic pathway. PT or INR, think play tennis, which is played outside. Extrinsic pathway. Also evaluate common pathway. Factors 2, 7, 9, and 10 are vitamin K dependent. Prolongation of both PTT and PT can result from vitamin K deficiency due to lack of intake, warfarin, liver disease, DIC, heparin, or direct oral anticoagulants. Heparin activates antithrombin 3 to inhibit factor 10 and thrombin at common pathway. Low molecular weight heparin has no activity with thrombin, only with factor 10. Warfarin vitamin K reductase inhibitor is needed to take vitamin K to its active state. If this cannot happen, no vitamin K factors are available. It does take time for the active vitamin K to deplete significantly enough and for synthesis of vitamin K dependent factors to stop. So a lot of times we will bridge Coumadin therapy with heparin, as Coumadin promotes clotting in the first few days. And then you would also want to keep in mind your reversal agents. Prothrombin sulfate for heparin, and then warfarin is vitamin K. The reversal agent for warfarin is vitamin K, but it does take time. So therefore, FFP may be given for immediate reversal, but you do need vitamin K to maintain it. So to review, the body has an injury, platelets come in to make a plug, the cascade of events occur that cause inactive enzymes to become active, and the end goal is to successfully stop bleeding, which is done through fibrin. So anti-clotting forces, these are inactive enzymes that become activated in sequences. The last two critical steps in the cascade are the activation of thrombin from prothrombin and the conversion by thrombin of fibrinogen into fibrin. Only fibrin molecules can begin the formation of a true clot. Fibrin threads create a mesh-like base to form a blood clot. After the fibrin mesh is formed, clotting factor 13 tightens it up and makes it dense and stable. More platelets stick to the threads of the mesh and attract other blood cells and proteins to form an actual blood clot. As this clot tightens or retracts, the serum is squeezed out and clot formation is complete. Because clotting happens so fast, in theory, it will continue to form fibrin clots until all blood in the body has coagulated and perfusion stops. So obviously this action would be lethal and deadly. That's why when the clotting cascade starts, anti-clotting forces are started to limit clot formation to damaged areas. So when this process is balanced, clotting occurs where it is needed and normal perfusion is maintained. The anti-clotting forces ensure activated clotting factors are present in limited amounts and cause fibrinolysis to prevent large clot formation. Fibrinolysis is the process that dissolves fibrin clot edges with special enzymes. So adding a layer of explanation, you have an injury and then platelet aggregation to that site. The cascade event occurs, prothrombin activates thrombin, that activates fibrinogen, which is the inactive enzyme released from the liver. This attaches to the platelets. It transforms into fibrin, and then after 24 to 48 hours, the clot dissolves with plasmin that destroys fibrin. Certain WBCs come and eat up the trash through phagocytosis, eosinophils and macrophages, and then normal blood flow is restored. Thrombocytopenic purpura. There are several different forms of thrombocytopenic purpura. So the first one we're going to talk about is ITP, or idiopathic or immune thrombocytopenic purpura. It's a coagulopathy that's an autoimmune disorder in which the lifespan of platelets is decreased by antiplatelet antibodies, although platelet production is normal. The patient's immune system begins making antibodies against the patient's own platelet membranes, and that's that antiplatelet antibody. When these antibodies attach to platelets, white blood cells attack and destroy the circulating platelets and those stored in the spleen faster than new platelets are produced. As the number of circulating platelets decreases, clotting is impaired. The second one is thrombotic thrombocytopenic purpura, or TTP. It's a rare yet life-threatening blood disorder in which the blood clots form in the body's small blood vessels, thereby impeding blood flow to vital organs. This abnormal platelet clumping together in the capillaries due to an autoimmune reaction from platelet aggregation results in an insufficient quantity in circulation. So you have inappropriate clotting that occurs, and clotting fails to occur with trauma. This process of increased clotting depletes platelets, and this increases the risk for bruising, bleeding, or hemorrhage if the patient is injured. And this can lead to kidney failure, myocardial infarction, and stroke, and it can be fatal within 3 months if it's left untreated. Heparin-induced thrombocytopenia, or HIT, is an immunity-mediated clotting disorder that causes unexplained low blood platelet count as a result of treatment with heparin. HIT can occur in patients receiving any type of heparin, although it is more common after exposure to unfractionated heparin. Type 1 HIT is the most common presentation. It's a non-immune mediated reaction that occurs even on day 1 of heparin therapy. It's usually a mild reaction that resolves spontaneously even if heparin continues to be administered. Type 2 heparin-induced thrombocytopenia is an immune antibody-mediated reaction that usually occurs 5 to 14 days following heparin treatment. This is a severe presentation of this disorder and can be fatal. Disseminated intravascular coagulation, or DIC, is a life-threatening coagulopathy in which clotting and anti-clotting mechanisms occur at the same time. A client who has DIC is at risk for both internal and external bleeding, as well as damage to organs resulting from ischemia caused by microclots. DIC is a systemic response to an underlying condition rather than being a singular disorder in and of itself. It occurs when hyperactive clotting leads to systemic development of blood clots. Conditions associated with acute DIC include sepsis, trauma, like massive head injury or burns, overwhelming inflammatory activation, intravascular hemolysis, obstetric complications, and even COVID, which was rare in COVID-19. Chronic DIC is most often associated with severe organ damage related to another condition like liver cirrhosis and malignancy. So for your assessment findings, there will be unusual spontaneous bleeding from the gums and nose, epistaxis, oozing, trickling or flow of blood from incisions and lacerations. You'll notice some petechiae and ecchymosis in the extremities, upper chest, and neck, and purpura, which is a reddish-purple fine petechial rash, would be noted. The patient may exhibit some hematuria or excessive bleeding from venipuncture, injection sites, or slight traumas, tachycardia, hypotension, and diaphoresis. Organ failure is secondary to microemboli, leading to respiratory distress. Cyanosis may be present, bluish, dark, or gray pigmentation in the nail beds, which indicates microvascular thrombosis, and redness, pain, warmth, and swelling of the lower extremities, mainly in HIT. So for your labs, you need to know the normal values of red blood cells, hemoglobin, hematocrit, WBC, iron, ferritin, platelet count, D-dimer, PT-INR, PTT, and the anti-10A factor, which assesses how long it takes for blood to clot. So your hemoglobin. Know the expected ranges for males, 14 to 18, and females, 12 to 16. This hemoglobin will be decreased with DIC and ITP. Platelet levels. The expected reference range is 150,000 to 400,000. And you'll see these decreased in DIC, TTP, and ITP. And this is called thrombocytopenia. Fibrinogen levels. The expected range is 200 to 400, and this will be decreased with DIC. Prothrombin time, remember this is extrinsic pathway, play tennis. It's increased with DIC. The expected normal ranges are 11 to 12.5 seconds. Remember this is the seconds that the time it takes for the blood to clot. International normalized ration, INR, is the extrinsic pathway. It measures the same as PT, but it's established as a standard, therefore easier monitoring. The normal range is 0.8 to 1.1. However, when it's used with Coumadin or warfarin, the goal of the INR is between 2 and 3. Partial thromblastin time, PTT, remember to think play table tennis, is in the intrinsic pathway. And this will be increased with DIC. Normal range for an APTT is 30 to 40 seconds, and a PTT is 60 to 70 seconds. The desired range for anticoagulation between 1.5 and 2.5 times the control value. So if the patient is on anticoagulation, we want the desired value to be 1.5 to 2.5 times the control value. The D-dimer, the expected range is less than 0.5 micrograms per milliliter, and this will be increased with DIC. Anti-factor 10A test measures the amount of anti-activated factor 10 in the blood. It's affected by low molecular weight heparin or unfractionated heparin and direct oral anticoagulants. So unfractionated heparin range is 0.3 to 0.7, and low molecular weight heparin is 0.15 to 1.2. Blood typing and cross-match is also needed. So on page 820 in your book, table 33.3, you have a lab profile. So a rule of thumb when you're trying to remember these numbers, so look at the RBCs. Take the low number for females and use it for your range to remember, and the high number for males as your high range to remember. So kind of use this approach when test taking. So when you're trying to remember platelets, think that you usually have 1.5 to 4 plates needed on a dinner table. So your range is 150 to 400 K. And if it's less than 150, then you have thrombocytopenia, which increases your risk of bleeding, as they are important for clotting. Remember, when the platelet count is low, thrombocytopenia, the patient is at greater risk for bleeding. Platelets are critical for blood clotting, and if they have values less than 20,000, they may experience spontaneous bleeding. So we want to communicate to our healthcare team, call for a rapid response team if signs and symptoms of internal bleeding are present, and then platelet count between 40,000 and 80,000 may experience prolonged bleeding from invasive procedures and trauma. You'd want to place patients with thrombocytopenia on safety or bleeding precautions, such as the use of an electric razor. So tests that measure bleeding and coagulation, remember, are your PT, your PTT, and your INR. So PT, extrinsic pathway, is usually a blue tube, and the lab tech measures the results. When they're measuring those results, they're looking to see how long the sample clots in seconds, usually between 11 to 12 seconds is the normal. Less than 11 seconds indicates that blood is clotting too easily or excessively. So thrombophilia, too many clots, You can call this hypercoagulability, if you can say the word. Greater than 12 seconds indicates that the blood has taken too long or longer to clot. And that might be the desired effect is in patients who are on certain medications such as Coumadin. Other conditions can occur that cause the blood to prolong clotting, such as liver disease, vitamin K deficiency, or clotting factor deficiency. So let's talk more about this vitamin K deficiency and how it can prolong PT time. Vitamin K is needed for different types of clotting factors. That goes for intrinsic, extrinsic, and the common pathway. If there is low vitamin K, the clotting cascade will not function as it should. Vitamin K equals clotting. Low vitamin K equals decreased clotting, and high vitamin K equals the risk of blood clots from too much clotting. There can be conditions that cause this, and it's not a desired effect, or we can give vitamin K antagonists to get the desired effect. Coumadin is one that you have to monitor the intake of your green leafy veggies as they are high in vitamin K, thus decreasing the effect of Coumadin and shortening the clotting time, thickening of blood and clots. Shorter clotting time, remember, equals clots too quickly, and you develop a risk of thrombus formation. Prolonged clotting time is thin. It takes too long to clot, and you have that risk of bleeding. Now let's talk about why INR is the go-to measurement over the PT. The INR, International Normalized Ratio, is in the extrinsic pathway. It's considered to be a more precise or standard PT level. The normal range, as we said, is 0.8 to 1.2. And when they're on Coumadin or warfarin therapy, the goal is 2 to 3. And you'll see that again, so make sure you stick it to memory. PTT, partial thromboplastin time, intrinsic pathway, the therapeutic range is 1.5 to 2 times the normal values when it's on heparin. That's why an APTT is measured for heparin, as they both correspond with the intrinsic pathway. You know, oftentimes people think that heparin breaks up clots, but it's not a fibrolytic. It is an anticoagulant that simply stops new clots from forming. The anti-10A factor test measures the amount of anti-activated factor 10, or anti-10A, that's in the blood, which is affected by heparin. It is used mainly to monitor heparin levels in patients treated with either standard unfractionated heparin or low molecular weight heparin, or those taking direct oral anticoagulants. The therapeutic range for an anti-10A is 0.3 to 0.7 for use with an unfractionated heparin, and 0.5 to 1.2 for low molecular weight heparin. Some imaging tests that may be performed are X-rays, CT, PET scan, MRI, just depending on the ordered workup to evaluate the cause of the hematologic or anticoagulation disorder. A bone scan may be ordered as well. The nuclear med scan is used to evaluate a bone disease contributing to a disorder of the blood components or plasma. Small amount of radioactive tracer is given through an IV, or it may be given inhaled or in oral dosing. The client is asked to lay still for about an hour during the scan. So you want to assess the patient for any claustrophobia, assess their coping mechanisms and some helpful interventions for laying still. You want to aid in reducing their anxiety by providing accurate information and emotional support. And anti-anxiety meds may be needed and to be ordered or given. There are no special precautions for a bone scan. The radioactive tracer is eliminated via the kidneys in a few hours. So you want to encourage the client to drink water to aid in that elimination. A diagnostic test that may be performed is a bone marrow aspiration or biopsy. This is found on page 824 in your book. You want to assess the patient, or it assesses the patient for certain cancers, anemias, wounds and blood disorders. And it provides information about bone marrow function, including the production of blood cells and platelets. It's an invasive and sterile procedure, so informed consent is required. It takes about 30 minutes for them to complete this test. Cells and fluid are aspirated from bone marrow, usually in the iliac crest, but it can also use the sternum or the femur as places. A larger needle is used to aspirate bone fragments, which is a biopsy. Heavy pressure is felt when aspiration of biopsy obtained with a crunching or grinding sound, so you would want to warn the client or patient about those, and they will be given a local anesthetic injection at that site since they may experience burning sensation when given that local anesthetic. A mild sedative can be administered as well, as this can be uncomfortable. So teaching your patients about follow-up care with the bone marrow aspiration or biopsy, you want to prevent excessive bleeding. So keep a close eye on that site for the first 24 hours after having the test done. If it's outpatient, you want to advise the patient to assess it every 2 hours for any signs and symptoms of bleeding or infection within that first 24 hours. They should avoid activities of potential trauma to the site for at least 48 hours, and then contact the provider if they notice any discharge, bleeding, swelling, or warmth. And then treat any mild pain they have with a cool compress or analgesic. You wouldn't want to give any NSAIDs as that increases their bleeding risk. Some nursing interventions and treatments for these clotting disorders, DIC, HIT, ITP, and TTP, you want to regularly assess vital signs and hemodynamic status. Monitor for manifestations of organ failure or intracranial bleed, such as oliguria, decreased level of consciousness. Monitor for lab values for clotting factors. Administer fluid volume replacement. Transfuse blood, platelets, and other clotting products as indicated. Monitor for complications from administration of any blood or blood products. Avoid the use of NSAIDs and administer supplemental O2. Provide protection from injury and implement bleeding precautions, such as avoiding the use of needles when able. With DIC, the initial focus is on assessing for and correcting the underlying cause, such as sepsis, malignancy, or hemorrhage. And then the focus turns to preventing organ damage secondary to microemboli and replacing the blood's clotting components. So we want to monitor for manifestations of microemboli, which would be cyanotic nil beds or pain. Medications to treat ITP are corticosteroids and immunosuppressants, or a splenectomy can be performed if the patient does not respond to medical management. TTP, antiplatelet medications such as aspirin, immunosuppressive therapy decreases the intensity of complications, and then plasma exchange is also an option. HIT, anticoagulants with direct thrombin inhibitor would be used. And in DIC, anticoagulants such as heparin can be used to decrease microclots from forming and using up clotting factors. So your risk factors for coagulopathy, it can occur secondary to an autoimmune disorder or extensive blood loss in which platelets and clotting factors are lost. So ITP. Risk factors would be female, sex assigned at birth, ages 20 to 50 years old. If they have any secondary conditions, medications, viruses such as HIV or hepatitis C, if they have any autoimmune disorders, or if they've had a recent virus, usually found only in children. TTP risk factors is an autoimmune disorders. HIT risk factors include the female sex assigned at birth, if they receive heparin longer than 1 week, exposure to heparin, unfractionated is more common, and post-surgical thromboprophylaxis, so the prevention of thromboembolic disease. And then DIC is secondary to other complications, such as septicemia, cardiopulmonary arrest, trauma, like hemorrhage, burns, crush injuries, cancer, and allergic reactions. Complications of blood administration is transfusion reaction. So you want to refer to your anemia disease process map. So platelets are given when the platelet count falls below 10,000 millimeters cubed, and to patients with thrombocytopenia who are actively bleeding or are scheduled for an invasive procedure. Platelet transfusions are pulled from as many as 10 donors and do not have to be of the same blood type as the patient. For patients needing multiple platelet transfusions, platelets from a single donor may be prescribed. This reduces the chances of allergic reactions. Platelet infusion bags contain about 300 milliliters for pooled platelets and 200 milliliters for single donor platelets. Platelets are fragile and must be infused immediately after being brought to the patient's room, usually over a 15 to 30 minute period. A special transfusion set with a smaller filter and shorter tubing is used. Plasma infusions may be given fresh to replace blood volume and clotting factors. More often, plasma is frozen immediately after donation, forming fresh frozen plasma or FFP. You want to infuse FFP immediately after it's thawed while the clotting factors are still active. ABO compatibility is required for transfusion of plasma products because the plasma contains the donor's ABO antibodies, which could react with the recipient's RBC antigens. Infuse the FFP as rapidly as the patient can tolerate, generally over a 30 to 60 minute period through a regular Y-side or straight filter tubing. When platelet level is low, the client is at greater risk of bleeding. So clients who have values between 40,000 and 80,000 may have prolonged bleeding from trauma, dental work, and surgery. A platelet value below 20,000 is considered critical. The patient may have spontaneous bleeding that is very difficult to stop. So nursing actions: take bleeding precautions. Assess for signs and symptoms as listed of obvious bleeding and evidence of decline in perfusion, oxygenation, and homeostasis, such as hypotension, tachycardia, decreased level of consciousness. If these are present, you want to call for a rapid response. Avoid invasive procedures unless necessary. Use soft toothbrushes, electric razors, and avoid contact sports. Monitor blood pressure and administer antihypertensive medications as prescribed, and then educate patients on the importance of avoiding forceful coughing, sneezing, or straining. Patient teaching. You want to instruct the patient to prevent any modifiable risk factors and stress the importance of follow-up lab monitoring and care with a hematologist. Teach them how to assess for any signs and symptoms of transfusion reaction based on the timing of the administration. Protection from injury and bleeding precautions should be done, and then take their medications as prescribed. This concludes this lecture.